Thank you so much. Thank you, Sujata. Thank you, Modini, for the kind invitation and the honor. I'll be speaking as asked on oncological principles in orbital surgery. Orbit is a box that's full of evil. You don't know what it is unless you have removed it, and pathologist obviously has the final word. So you have to combine your oculoplasty surgical skills with oncological principles. Otherwise, there might be situations where you might end up compromising life. Primary goal in any malignancy would be life salvage, and if that is possible, eye salvage, and tertiary goal would be optimal vision and cosmesis. So whenever you have a patient with an orbital tumor sitting in front of you, you have to ask these questions and answer these yourself. What is it likely to be? Is it a benign tumor or a malignant tumor? Where is it located? Intraconal, extraconal? Does it have extra orbital extensions such as to paranasal sinus or intracranial extension? What are its relationships? Is it related to extraocular muscles and the optic nerve? Is it operable at all or not? And if so, what approach would I take? Would I take transconjunctival approach, or would I rather do transcutaneous approach? Would I cut the bone? Would I not? What do I expect? Do I want to completely remove it, or would I just want to get away with an incisional biopsy? When you have to ask these questions and reliably answer before you counsel the patient and schedule a patient for surgery, you have to go through the logical step necessarily of clinical history, regional examination, relevant systemic examination as is appropriate with your differential diagnosis. Imaging, it could be ultrasound B scan, MRI or CT scan, or even a PET CT scan, special investigations, surgery, and of course histopathology, most important, because based on that would you devise adjuvant therapy. So when you go through this approach, you have three conclusions. What do I do? Do I say no to surgery? That's a very clear answer. Of course, you won't do surgery in certain situations. I'll show you which. In certain situations, you'll definitely do surgery. And there are some gray areas where, depending on your competence and the facilities that are available, you may or may not do surgery. So with this approach, this is a patient child with bilateral proptosis with temporal fossa fullness, where you expect there to be a triradiate lesion involving the temporal fossa, orbit, and intracranial extension, bilateral without any periocular hemorrhage. Your primary differential diagnosis would only be metastatic Wilms disease, and you won't even do a biopsy here. Whereas exactly similar situation, triradiate lesion with raccoon eye sign or periocular hemorrhage bilateral, you would definitely consider metastatic neuroblastoma. Again, no surgery here. A child with unilateral proptosis, subconjunctival hemorrhage, rot spots in the fundus, you have no other differential diagnosis except granulocytic sarcoma, and the child also only needs a peripheral blood smear to confirm the diagnosis that it is AML, and you send away the child to a pediatric hemato-oncologist. No biopsy here, not even a scan yet. This is a patient with prior history of multiple myeloma, now comes with an orbital mass after 10 years. You know the history that it is a case of multiple myeloma. So all you want to now confirm is the diagnosis that it is plasmacytoma, and FNAC would just suffice. You really don't have to open up the orbit. That being so, there are some non-surgical approaches to orbit as well. Like this patient, he doesn't even seem to have proptosis. Does he seem to have proptosis at all? I don't see it, right? Maybe half a millimeter difference in exophthalmometry. But he's been failed in his recent medical exam. He was a pilot because of this posterior orbital mass, which we know already on MRI that it is most likely to be a cavernous hemangioma. But it is peeping into the superior orbital fissure, pressing on his optic nerve, causing his visual field defect, because of which he was failed in his recent medical exam. So would you want to approach this by surgery? Definitely it is possible. Cavernous hemangioma is a surgeon's delight, but being in this location, there is always a possibility that you might damage structures that pass through the superior orbital fissure. Even if you don't want to intentionally damage, when the tumor comes out, it may pull on some of the nerves. There could be a secondary hemorrhage, there could be further pressure on the optic nerve, or even optic nerve sheath hemorrhage, which may result in compromised vision and also functional deficit, which he currently doesn't have. So in these situations, you choose not to do surgery, but he wants his visual field back, so you plan stereotactic radiation just to this benign tumor, and you can show that the tumor has reduced by about 70% of its initial volume. Residual lesion is only about 30 to 40%, thus relieving pressure over the optic nerve and complete reversal of his visual field defect. So with a good radiation oncology facility, you can plan to radiate just the tumor itself, avoiding bystander effect to the optic nerve and the retina. This is from the literature, where a much smaller dose of 2000 centigrade using gamma knife was delivered for a smaller, much smaller lesion with much severe visual field defect, and there is complete reversal of visual field defect. So radiation could be considered in a patient who has a pear-shaped lesion where there is no clearance at the orbital apex, where surgical maneuvers can be dangerous. Injections, of course, has been overemphasized recently. There are drugs that are available for lymphangioma. There are many drugs including tetracycline, but picibanil and bleomycin are currently preferred. Picibanil is a very gentle drug for the optic nerve, that is why it is preferred. Bleomycin is good enough. Now this is a young lady who comes with unilateral proptosis. Her only complaint is that she doesn't look good and she has periocular hemorrhages and subconjunctival hemorrhages which happen on a recurrent basis and take time to resolve. And during the phase of resolution, she always has that hesitancy in facing public because she has subconjunctival hemorrhage. Now she has a tumor which is all around her optic nerve, lateral rectus, lacrimal gland, SRL complex and the medial rectus. So you cannot easily debulk this even by the supratemporal approach. In such a situation, we would use picibanil and not bleomycin because we are injecting right next to the optic nerve in the intraconal space, and you can see nice tumor clearance over 3 injections, and she has actually got the cosmesis that she always wanted. Tumor may not always completely go away, but sclerosis enough not to remain symptomatic. In a patient with who has macrocystic lymphangioma where there is chocolate cyst, you would simply aspirate the content of the cyst and inject bleomycin, and this is one such patient who is relieved of his chocolate cyst. Another child who has acutely bled in a pre-existing lymphangioma with corneal exposure, etc., following evacuation of the contents, that was clotted blood, and injection bleomycin. Anteriorly located lymphangioma, again injected with bleomycin. So injections are definitely the way to go for venolymphatic malformations. Now this is a patient who has a kind of a subacute or a chronic proptosis, and based on the location of the lesion and triradiate, of course, you suspect that the child may have eosinophilic granuloma, but there is no proof as yet. For eosinophilic granuloma, curettage is the treatment of choice, but since it has already disturbed the dura and there is no roof of the orbit, curating in this area would mean that there could be CSF leak, and that would also cause for orbital reconstruction, which would make the surgery more morbid. So in such a situation, we would go with the safe approach of doing a biopsy from the center of the lesion without going much towards the dura and wait for the pathologist to confirm the diagnosis. Most of the ophthalmic oncopathologists are confident enough to give this diagnosis on a imprint or even squash cytology or frozen section, and if they confirm the diagnosis on the table in about 10-15 minutes while the child waits under anesthesia, you would go ahead and inject the lesion with triamcinolone. Just that, and then you can see 3 months later the bone is partially remodeled, 6 months later bone is completely remodeled without needing a major surgical intervention. So this is possible if you have a situation where your pathologist is able to support your rapid diagnosis while the patient waits under anesthesia. This is one more recent patient where there was a breach in the roof which is now settled down, and the lesion is on its way to regression following triamcinolone alone. Now about incisional biopsy. There are clear indications for incisional biopsy. If a lesion is poorly circumscribed, when you suspect a malignant lesion, when you cannot remove it completely without causing functional issues, and you have a differential diagnosis, not a definitive diagnosis based on your clinico-radiological evaluation and systemic workup, you would want to do an incisional biopsy because you don't know what it is and how else it can be treated. In such a situation, doing a biopsy is okay. But if you look at the literature, you find that about 8 to 20% of orbital biopsies either result in non-specific or misleading wrong diagnosis, leading to inappropriate treatment. If you have a wrong diagnosis, you go on it and treat the patient, which may not result in resolution. I'll tell you upfront that it's a child with rhabdomyosarcoma of the orbit. I'll also show how I do biopsy. When I do biopsy in this patient, I know the epicenter of the lesion is this on radiology. So I would do a superficial biopsy, I would do a mid-zonal biopsy, I would do a deep biopsy and send all this to the pathologist. Or you can do a deep biopsy where all the part of the lesions are included. But you should definitely go beyond the epicenter of the lesion, because if this is the lesion, the epicenter would consist in a round cell tumor of necrotic element, the mid zone would have the real tumor, and the periphery would be the tissue reaction to the necrosis or inflammation that a round cell tumor would induce. So if you do biopsy only from the superficial lesion, this is what it would show: inflammation and fibrosis. Now based on that, if you treat the patient on oral steroids, it will partially resolve, and you get into the aspect of being confident that okay, it's going to resolve, but the child is going to obviously get metastasis. So in such a situation, what gives you the diagnosis would be either a mid-zonal or a deep biopsy, which confirm the diagnosis of rhabdomyosarcoma here, so we could further treat the child. This was a bilateral orbital mass with telecanthus, which is acquired. Now in this patient we did a biopsy, and superficial biopsy showed inflammation and fibrosis. Deep biopsy simply showed granulomatous inflammation, which would still warrant steroids after systemic evaluation, but only when we asked for special stains could we diagnose that it was indeed a fungal granuloma, where steroids would absolutely be contraindicated. So unless you ask for special stains in a given clinical situation, the pathologist may not do it. Or if you don't ask for microbiology evaluation or preserve some fresh tissue for PCR, you may not get the diagnosis. So you don't have a second chance here. You should anticipate the diagnosis and get appropriate investigations. In excisional biopsy, the indication is that it should be a well localized and a circumscribed lesion which is non-infiltrative and not associated with crucial structures. Irrespective of whether it is benign or malignant, you would completely excise. There is no role for an incisional biopsy in a well circumscribed tumor, because if you want to leave a part of it behind, how else can you manage it? It's very difficult. So when such a situation arises, there are many surgical approaches. Anterior orbitotomy, of course, there are many named and unnamed incisions. It can be used for dermoids, lymphangioma. Now it's treated, of course, with injections, but earlier we would even do a lid split incision, which is called Byron-Smith incision, to access a suprarenasal lesion. But currently all that is gone, and we do a safe lateral orbitotomy approach where we go by the lid crease mostly, and if at all it's a lacrimal gland tumor, we may go with a very lazy stellarite incision. These are the two popular incisions currently used. But what is also important to know is that there is minimal surgical approaches now, which is by the conjunctival approach. This is to show that about 70% of the orbit is accessible by conjunctival approach. Medial for sure, intraconal or extraconal, inferior definitely, lateral up to the lacrimal gland. Superiorly you cannot do conjunctival approach because the superior, of course the LPS would come in the way and you would cause ptosis. So there are many incisions in the conjunctival approach. This is a child with a teratoma, where it was a benign teratoma, where the lesion was both on the medial as well as the lateral side of the optic nerve. That's a fully grown molar tooth within it, confirming radiologically the diagnosis. That's a swinging eyelid incision that we used. That's a cystic lateral component. That's the optic nerve. We could visualize it under the microscope. And the medial component was much tough and solid, and that was the groove through which the optic nerve was passing. That's the medial, and that's the cystic lateral component, all of which could be visualized and removed by this approach. Now all the child now has residual is an esotropia which can be fixed. Optic disc edema is completely gone, so the child has good visual prognosis. Now this is a lady with an intraconal cavernous hemangioma. She is a professional. The lesion was pressing on the optic nerve and she did not want a bone cut, and she wanted to go back to work very soon. In this situation, again you can use a transconjunctival orbitotomy approach, where you would not cut the bone at all and then do a minimal surgery. This is a lateral canthotomy incision, which is just about 5 mm. Inferior cantholysis to get egress to the inferior fornix. Quickly forward the video. Conjunctival incision has been made. The bone is ledged, and you expose the periosteum very close to the inferior orbital margin. Once the periosteum is exposed, you make an incision in the periosteum, again very close to the inferior orbital margin, not to damage the infraorbital nerve. Then you dissect the periorbita until you either visualize the inferior orbital fissure, the apex of it, or the infraorbital nerve, both of which you don't want to damage. And once that is done, you have to make an incision in the periorbita in the quadrant where the tumor is located, after cauterizing the blood vessels which are bleeding through the bone. That's the incision in the periorbita we are making in the quadrant where the tumor is located. Rest of the dissection is carried out by blunt dissectors to visualize about 2/3 of the tumor. When the lesion becomes easily ballotable, then you apply a cryoprobe for a good anteroposterior traction and gently ease the tumor out without pressing on the optic nerve at any point in time, and always looking at the pupil. And as the tumor comes out, there is no hurry at all. You have to look at the posterior aspect of the tumor for a possible feeder vessel, and that needs to be cauterized. Otherwise, that blood vessel will retract into the orbit, bleeding, maybe causing secondary hemorrhage. So that's a feeder blood vessel that was cauterized. And now all we need to close is just the lateral canthotomy wound that we have made. It's a 5 mm cut, the minimal access to the orbit, and most of the tumors in the lateral, inferior and medial orbit can be accessed exactly similarly, and conjunctival closure is also easy, and morbidity is very minimal. The same patient looks like this after about 3 weeks without any morbidity of lateral orbitotomy. This was a neuroblastoma approach by the similar approach. I'll skip this video, lateral orbitotomy without a bone cut. But what next after surgery? Of course, the pathologist will tell you the diagnosis, and based on that, you might want further treatment. This was a mantle cell lymphoma which needed rituximab treatment, and of course, many patients we have been able to avoid orbital exentration. There's a child with orbital retinoblastoma by just doing enucleation after multimodal treatment, giving them good cosmesis. One more child with orbital retinoblastoma treated similarly. Approach is used for abdominal sarcoma as well, where the tumor is around the inferior rectus muscle. For example, this child has a large inferior orbital mass and it is located around the inferior rectus muscle. If I were to completely remove it, I would sacrifice the inferior rectus, thus causing refractory strabismus, which is very difficult to repair. So what we do in this situation is leave a bit of the tumor around the inferior rectus and remove the rest. So that groove has been left along the course of the inferior rectus muscle, and rest of the tumor has been removed. Rest of the treatment, of course, is by multimodal treatment, which anyway the child needs in RMS, chemotherapy and radiation, and you can maintain function and vision. This is a child destined for exentration. There is no reason why we should not do it, but it is not safe at this point in time when the patient has presented. So we chemo-reduce this patient, do a safe exentration, then we can use the skin flaps to provide an exentration prosthesis. In adenoid cystic carcinoma, the protocol is established that we have to begin with neoadjuvant chemotherapy, shrink the tumor down, and then do a complete en-bloc excision and chemotherapy and radiation. So basically, patients who have bone involvement now don't need an orbitectomy. They can be conserved, bone remodeled. So you can see the same patient after complete remodeling of the bone. This is a child with adenoid cystic carcinoma with bone involvement, completely remodeled following multimodal treatment. They don't need morbid orbital exentration. So in conclusion, I would say that sebaceous gland carcinoma, which Anusua already showed. In conclusion, I would say that exentration can be avoided in many of these patients, and logical approach to orbit, starting from a good clinical history, radiological evaluation, clinico-radiological correlation, then deciding on whether you want to do an incisional biopsy and excisional biopsy, taking safe approaches to excisional biopsy, relying on the pathology for adjuvant treatment helps optimize the outcome. Thank you so much. I think I can skip that because the next step.
Very beautiful lecture as usual, and I'm sure all of us are going back learning much more than we came with. It's always very, I find every conference, every session a learning tool for myself.